This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology and training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Welcome to the Neurology Recall episode for May 2024. It's Jeff Ratliff, Deputy Editor of the podcast. May is Brain Cancer Awareness Month, and this month we'll be featuring 4 fantastic podcast conversations about topics in neuro-oncology that aired throughout 2023. The first episode you'll hear is a conversation between Kate Nebel and Philipp Karschnia about MTHFR polymorphisms in primary CNS lymphoma patients that aired on the October 19th, 2023 episode of the podcast. The next 2 conversations you'll hear focused on treatment developments for CNS tumors. On March 2nd, 2023, Kate Nebel spoke with Linda Liau about the use of vaccine-based therapies for the treatment of glioblastoma multiforme. On July 20, 2023, Kate returned to the podcast to talk with Ingo Mellinghoff about Vorasidenib for the treatment of IDH-mutant gliomas. To wrap up this month's Neurology Recall, you'll hear Farah Mateen speak with Teddy Totimeh about the need to improve brain tumor care resources in Asia and Africa. Thanks for listening to the Neurology Podcast and the Neurology Recall. We'll see you next month.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology Podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, my name is Kate Nebel. Today I'm talking to Philipp Karschnia, a resident physician at University of Munich in Germany, who's first author on a recently published paper, Association of MTHFR Polymorphisms with Leukoencephalopathy Risk in Primary CNS Lymphoma Patients Treated with Methotrexate-Based Regimens. Philipp completed this work during his postdoc fellowship at MGH. And today I am really looking forward to talking to you, Philipp, about this paper.
Yeah, thanks so much for having me.
I can't wait to get into the details of your paper some more, but before we do, can you tell the listeners what you think the most important message is from your study?
Methotrexate is certainly the backbone of any therapy for primary CNS lymphoma. We know that it often causes leukoencephalopathy, and this leukoencephalopathy may then translate into cognitive complaints of patients. And we don't really have a biomarker other than age to identify individuals at risk. And in the current study, we found that there's a common polymorphism of a gene which encodes for proteins which are involved into the methotrexate metabolism. And those polymorphisms may represent a biomarker to identify individuals at high risk to develop leukoencephalopathy following treatment with high-dose methotrexate. And we also provide evidence that this kind of polymorphism is not only associated with imaging findings, but also linked to inferior clinical outcome when compared to patients without that polymorphism. This polymorphism may really serve for a risk assessment to guide patient management when it comes to therapy with high-dose methotrexate for primary CNS lymphoma.
And building off of that, could you go into a little bit more detail about mechanistically how these polymorphisms can play a role in terms of the risk of leukoencephalopathy with methotrexate exposure? And what made you think to even look at this in the first place? What do we already know about these polymorphisms before your study?
High-dose methotrexate, as said, is the standard of care for newly diagnosed primary CNS lymphoma. And pharmacologically speaking, it's a potent antagonist of the folate pathway. And as said, besides having acute side effects, it often also causes leukoencephalopathy. And MTHFR is a gene which is encoding for protein, which is a critical regulator of folate levels within the tumor cells, but also physiological healthy cells. And MTHFR polymorphisms are pretty common. So about 70% of the healthy population, depending on race, do have polymorphisms within that MTHFR gene. And those MTHFR polymorphisms have been linked to altered metabolism of high-dose methotrexate within tumor cells, but also within physiological cells. And we know that in terms of systemic toxicities, MTHFR polymorphisms are being associated with more severe and more frequently encountered systemic toxicities, mainly including liver toxicities. So it's very tempting to speculate that polymorphisms of the MTHFR gene may also result in a higher rate of CNS toxicities or more severe CNS toxicities.
On that note, can you tell us a little bit more about the study design and who you included in the study, how you identified patients?
We retrospectively identified patients which have been treated for primary CNS lymphoma at Mass General Hospital in Boston. And we identified all patients who have been treated with high-dose methotrexate as an induction first-line chemotherapy between the years 2000 and 2022. And we excluded all patients in which we had a follow-up time of less than 6 months and who within a period of 5 years following high-dose methotrexate have received either CNS-directed radiotherapy or intrathecal chemotherapy, as both radiotherapy as well as intrathecal chemotherapy might themselves induce leukoencephalopathy and might dilute any association between a high-dose methotrexate and leukoencephalopathy. And from all those patients, we collected clinical information when we had MTHFR status available for our review. And this left us with 68 patients, most of them being Caucasian. And why I mention that here is because there are certain differences in the prevalence of MTHFR polymorphisms depending on race. And from that 68 patients, about 1/3 of them had a missense mutation in the position 1298. About somewhat more than 1/3 had a missense mutation in position 677. And only 10% of the patients did have a normal genotype, which is somewhat less than we would expect. And those 68 patients represented our study cohort.
One of the things that I found a little interesting about your study was how many patients were able to identify who had the MTHFR polymorphism mutation, assessed even. And so I was wondering if that's common practice, if MGH, or if that's something that you feel like is standard.
I don't think it's standard of care throughout the entire country or even in Europe. It's certainly not standard of care. At MGH, we indeed started to test every single patient since a couple of years because there have been publications on the association between MTHFR polymorphism and systemic toxicities, such as liver toxicities. And in those patients, it might also have therapeutic implications because we might do some accelerated leucovorin rescue and really be more careful regarding patient monitoring and follow-up. Nowadays, every newly diagnosed PCNSL patient at MGH does get testing for MTHFR mutation, but certainly not 22 years ago. That's why the number of patients in our cohort is also that low.
Sure. Can you tell us a little bit more about the outcome measures that you looked at to assess for leukoencephalopathy and what the most important findings were from those assessments?
We looked at two big things. One are radiographic findings. So we looked at the MRIs of each individual patient at baseline and 6 months following high-dose methotrexate, 1 year, 2 years, and 5 years after high-dose methotrexate. And on those MRIs, we assessed the non-tumor-bearing contralateral hemisphere and assessed whether white matter disease, depending on the severity, so either not being present at all or being very mild in nature, which we defined as less than 1/3 of the hemisphere being affected, or severe, which we define as more than 1/3 of the contralateral hemisphere being affected. And the second thing we looked at were response and survival data. So we collected data on disease response to induction chemotherapy, but also progression-free and overall survival. And what we found was that the MTHFR polymorphism, which has a missense mutation at the 1298 position, was associated with the development of leukoencephalopathy. So about 70% of patients who had this missense mutation eventually developed some kind of leukoencephalopathy, as well as with severity of leukoencephalopathy. 6 of the 9 patients who had severe leukoencephalopathy also had that genotype. We did not find any difference in disease response or progression-free survival between patients with and without the polymorphism at a median follow-up of about 10 years, but a lower overall survival in patients with that missense mutation in position 1298 when tested against individuals without this genotype. And it's very tempting to speculate that the higher rate of leukoencephalopathy and the more severe leukoencephalopathy might have translated into a reduced clinical status, eventually prohibiting those patients to undergo further therapy once the tumor has progressed or recurred.
Did you include, and I can imagine this would be really hard to do retrospectively, but include any additional measures of potential impact of leukoencephalopathy in terms of like cognitive functioning and neurological function?
That's a wonderful question, and that's certainly a very important limitation. So I think that's not only a limitation for our study itself, but for a little bit for the entire field of neurotoxicity and white matter disease, right? Because we don't really have good studies in prospective cohorts to correlate white matter injury with functional and cognitive outcome. And as you pointed out, it's very hard to do this in a retrospective study. So we did not have formal neurocognitive testing available for our review. So it remains a little bit speculative whether the association between inferior survival and leukoencephalopathy and that genotype really were due to reduced cognitive function.
What do you think is next in terms of assessing this association further or understanding it better and how it may impact patients or patient treatments? And I'll add one more qualifier to that. In terms of leukoencephalopathy, we don't have great treatments, as you know, for treatment-related leukoencephalopathy. So just wondering what your thoughts are on what's next.
I think for that certain polymorphism or gene as a risk factor for leukoencephalopathy induced by high-dose methotrexate, I think it's very important to have our findings verified, both in our retrospective cohorts, but also to incorporate that kind of testing into prospective clinical trials protocols to make sure they are really valid. And as you pointed out, there are not too many strategies to mitigate symptomatic leukoencephalopathy or leukoencephalopathy at all. There's this term which has been coined as chemo brain, and there are a lot of agents out there which have been used, including CNS stimulants, drugs which are being used for memory impairment, and even bone marrow supporting agents. And beneficial effects have mainly been reported in children undergoing, for instance, whole brain radiotherapy or systemic chemotherapy or some childhood cancers. But efficacy in adults really varies across different studies. Anti-dementia drugs may work to some extent, but clinical experience is really limited. And there are also some preventive strategy on the horizon. So when I think about what is next by combining such novel therapeutic approaches for cognitive dysfunction together with our findings, I would say that patients with such an MTHFR polymorphisms scheduled to undergo high-dose methotrexate are probably the ones which you want to see enter a clinical trial, because you would think those are at high risk to eventually down the road develop cognitive complaints, and you want to match them into any trial which aims to prevent and stabilize myelin function as early as possible. So I think that would be the next step once our findings are validated.
Thank you so much. This is a really interesting paper, and I'm looking forward to seeing what's next and how this may impact future patient care and improve patient care, and able to, as you say, maybe find a way to prevent treatment-related leukoencephalopathy or lessen it based on risk factors and identify those patients who are at most risk.
This was wonderful being here, and thanks so much for letting me discuss our findings.
Hello, and welcome to the Neurology Podcast. This is Kate Neville from Indiana University. Today I'm talking with Ingo Mellinghoff, Professor and Chair of the Department of Neurology at Memorial Sloan Kettering Cancer Center, on his article, Vorasidenib in IDH1 or IDH2 mutant low-grade gliomas, published in the New England Journal of Medicine last month. Ingo, thank you so much for talking with me today about these exciting results from your study.
Thank you for having me.
Before we discuss more of the details of the study, can you share with the listeners some of the background and motivation behind the study? So, in other words, Why was this study done and why is it important?
This study is about a drug called Vorasidenib, and it is the first targeted agent to improve patient outcomes in low-grade glioma. And that really is a bit of a new landmark here, and that's why it's worth really getting into the weeds about it. And the potential approval of this drug could delay the need for more aggressive therapy in this disease, low-grade glioma, and we're very excited about the results and what they mean. And the reason why this study was done, it is about grade 2 glioma in adults. And grade 2 gliomas are a slowly progressive malignant brain tumors with a poor long-term prognosis. Even though grade 2 gliomas are often referred to as low-grade diffuse gliomas due to their slower progression, compared to the better-known glioblastomas, they cannot be cured and they cause significant disability. As you know, mortality, premature mortality for patients who have this disease. And the patients who have this disease, they're typically young, about 40 on average. And of course, a very active period in their lives. They're striving to balance a family life, a professional life, raise children. And these patients really are in great need for a therapy that potentially is less toxic than what is currently offered. And the standard of care for these patients as of today is starting with surgery, maximal safe resection of the tumor. And then after the surgery, there is a choice that has to be made whether there should be immediate follow-up treatment with radiation and chemotherapy or a watch and wait period when these patients get their regular MRI scans and neuro exams, but no additional therapy. And that, of course, is a very difficult decision to make every single time. And many patients, when possible, choose this watch and wait period. And there are a number of criteria, as you know, that we apply to make that decision. And what's really exciting that these tumors were found in 2008 to very frequently have a mutation in this metabolic gene called isocitrate dehydrogenase, or IDH. And there's actually two genes, IDH1 and IDH2. And the great majority of the grade 2 gliomas do have a hotspot mutation in either IDH1 or IDH2. And we now know what these mutations do. They disrupt the metabolism of these tumors, and they have a very distinctive set of molecular alterations. And this drug that we're talking about today, Vorasidenib, is an oral inhibitor that targets mutant forms of IDH1 and IDH2. So it's a dual inhibitor that was specifically designed to be brain penetrant. And that, Kate, as you know, is of course unusual that we develop or companies develop a compound specifically for brain tumors. So that was already a first important step with Vorasidenib. So that is why the study was done. There's a target, there's an opportunity to shut down the function of the mutant enzyme, and there is a patient population that would really benefit from a therapy that is less toxic and could be introduced early in the disease course. And the IDH mutations, just to finish that thought, they are disease-defining in this low-grade glioma group. They're part of the WHO classification of this disease. And these mutations really are considered to be drivers, and they remain detectable throughout the disease course, even as these tumors progress. So the mutations do have a lot of the hallmarks of what we would traditionally consider a driver in cancer.
Thanks so much for going over that. That was great. And, this is such a nice study. You have your target. You have a drug that was developed specifically for brain tumors. And you have your patients who are in this time frame of this watch and wait period, which is really what you're targeting here after surgery, but before any other treatments. So with that, what are some of the highlights of the study design and characteristics of the patients included in this study?
The Indigo study was a global phase 3 study. It's double-blind, placebo-controlled, randomized, that enrolled patients across 10 countries. So it was a substantial effort, 77 centers. And the goal was to assess the efficacy and safety of daily vorasidenib in patients who had residual or recurrent grade 2 IDH1 or IDH2 mutated oligodendroglioma or astrocytoma. So grade 2 is important here, and residual, we actually did require the presence of measurable disease at enrollment. And the patients were patients who had only received surgery as their only prior treatment. That's important as well. And they were not in need of immediate chemotherapy or radiation according to their treating physician. The primary endpoint of this study was progression-free survival based on a blinded independent imaging review. So that is very important. So it's imaging-based progression-free survival, and an independent review committee made the decision when progression occurred. And that committee was not aware of the assignment to which treatment group each patient was in. Time to next intervention was an important key secondary endpoint. Patients were stratified by 1p19q status. That is a molecular alteration that distinguishes what we call oligodendrogliomas from the astrocytomas. And another stratification factor was tumor size. And then what is also important, patients were randomly assigned to either placebo or study drug, but at the time of imaging-based tumor progression, they were offered the option to cross over. That was an important feature of the design, crossover to the vorasidenib arm. Otherwise, patients had to be 12 years or older and with a KPS of at least 80. And the other eligibility criteria, I think we went over. Again, in summary, as a sort of takeaway, these were patients who were in that watch and wait period that we discussed a little bit earlier, where they had the surgery, they did not yet have radiation or chemotherapy, and they were in that period of time when we watched them very closely with regular MRI scans. And in that setting, they got either the study drug or placebo. So that is a setting where I think maybe the only setting where you can really very cleanly isolate the activity of investigated novel agent in a placebo design.
That's great. And can you explain just a little bit what you mean by the where you can cleanly evaluate just with the prior radiation exposure versus not piece?
I would say there are two parts to this answer. The first one is the placebo versus active drug. That, of course, is a design that we rarely use for the evaluation of agents for brain tumor patients. And that you can really do in a setting, in a disease setting where watch and wait is a widely accepted standard. So, and that is different from what we often do for the evaluation of brain tumor drugs, which is evaluate them in the recurrent setting, where that would not be an easy or even possible thing to do. So that's as it relates to the placebo part of the design. The other aspect I think that you were alluding to is that once patients receive radiation for their brain tumor, there are a number of radiographic changes on the MRI scan, gliosis or scarring we sometimes refer to, that make it sometimes very difficult to distinguish a non-enhancing tumor growth from radiation-related sort of secondary treatment-related changes. And that is making it very difficult to evaluate molecularly targeted agents in that setting after radiation. And as you know, we struggled with the response assessment in neuro-oncology for quite a while because of the limitations in the imaging. And again, that was the advantage of this current study, that none of the patients had radiation prior to going on study, so that we could take that off the table altogether as a confounding variable.
What are the most important results of the study?
The most important result is that at a pre-planned interim analysis, vorasidenib demonstrated a very clear and significant improvement in progression-free survival per blinded independent imaging review compared with the placebo group, with a reduction in risk of disease progression or death by 61%. So that is a pretty hefty, strong result. And that is what led the independent data monitoring committee to recommend unblinding of the study in March of 2023, which we, of course, did immediately. And the median progression-free survival in the study strongly favored the vorasidenib arm, with a median of 27.7 months versus 11.1 months for the placebo arm. And this benefit in progression-free survival really was consistent across all of the patient subgroups, regardless of the time since surgery, number of prior surgery, presence or absence of 1p19q. And the key secondary endpoint, which was time to next intervention, was also significantly delayed by 74%. So altogether, that's a very strong result, I think a clinically meaningful result. And importantly, the study drug was overall tolerated very well. Adverse events that occurred more frequently with vorasidenib than placebo did include increases in LFTs, transaminases, but the liver function abnormalities were reversible and they did not lead to any significant problems. So we were really very excited how well this treatment was tolerated. So it's both the great tolerability as well as the strong result. I think that makes us excited about this study.
Yeah, absolutely. Because so many things that we give to patients in neuro-oncology can make people feel poorly, or they have fatigue or other side effects. And this is something that really seems like that wasn't the case. So that's really exciting too, in addition to it being effective or showing, efficacy. And one thing that you mentioned earlier about the study design and the ability to cross over, that was really so wonderful, that when you unblinded everybody based on the interim analysis, that all the patients had the opportunity who are on placebo to then go on to study drug if they chose to, which was great too.
And most patients took us up on that opportunity. So.
Yeah, absolutely. So how do you see these results changing the way that we treat patients with IDH-mutant low-grade gliomas?
For me, there are 2 or 3 key findings. One is it is an important first step toward less toxic and more precise cancer therapy for these young patients. It is clear, the study, like any other study, had specific eligibility criteria. And every time you have a patient in front of you, you'll see if your patient fits these criteria. And it is clear that we're just opening the door to progress in this disease. There is a target that is very important. And we actually didn't really know this before the study. There was some discussion to what extent the mutant IDH enzyme indeed contributes to the growth of these tumors once they have developed. Right? It's something we've been talking about on the scientific side. And it is very clear, based on the INDIGO study, that the mutant enzyme is a drug target in this disease. So I think that's opening the door to combination therapies in various settings, exploration of targeting the mutant enzyme in different settings, as monotherapy as well. And it is really about opening an entire line of investigation, I think, besides the obvious, most immediate impact of having a new tool in the armamentarium of the neuro-oncologist, hopefully in the future. And then I think the other, to me, exciting part is that, we really haven't, as you know, Kate, very well, we really haven't made a whole lot of progress with developing new therapies for primary brain tumors, and in particular glioma. So I think our field has suffered quite a few setbacks. And what the INDIGO study really represents is the culmination of a series of investigations that were really methodical and highly collaborative that led to a positive phase 3 finding. And for example, after the phase 1 study that just established safety, we actually conducted a window of opportunity study just to be 100% sure that the drug does get into the tumor, does turn off the mutant enzyme, does change the expression of the genes that we think are important, does result in lower tumor cell proliferation. So that was an additional step that we took prior to picking the agent and the dose for INDIGO. And I think investing into this additional step, which requires resources, commitment, expertise, assays, and all of that. But I think that was really a key step. And I'm hoping that we can learn from this as a broader lesson for our field, that this is how we want to go ahead and develop new agents for primary brain tumors. Start with a compelling compound that perhaps was designed specifically for brain tumors based on the genotype or the blood-brain barrier penetration or both, but then also commit to these sort of window of opportunity studies to be 100% sure that the drug actually goes in. Because Kate, you and I have looked at all these single-arm studies that give perhaps a promising signal, but then fail in phase 3. So we're hoping that maybe this could be a path forward for drug development. And I think that would be a larger conclusion perhaps from Indigo, hopefully. This happened during the COVID pandemic. We enrolled 331 patients during the COVID pandemic in all these different countries. And it speaks to the need for our patients to come and participate in a clinical trial during this, but also the commitment of the company and the investigators, the study teams, and all of that to see it through. And it was concluded in a relatively short period of time. So these are all things that I'm excited about.
Absolutely. What long-term follow-up is planned, and what else do you think will come out from this study, a group of patients?
We're continuing to collect follow-up data as part of this study protocol, and we will be presenting new data, from this study as it becomes available. For example, as it relates to volumetric studies that we've done to assess tumor growth rates. It is key to remember that this is the final result. This was a pre-planned second interim analysis. Everyone is unblinded. And so this, to some extent, this has to be viewed as a final result. But we will definitely be very curious to find out, in the next 5 to 10 years, exactly what happens to these patients over time. I think as a field, these are the questions I think that we're asking ourselves. What are the potential mechanisms of resistance? What is the role of combination therapy? This is, I think, the beginning of an exciting new series of trials and investigations.
Yeah, absolutely. Well, thank you so much for talking with me today, Ingo.
It's my pleasure, Kate. Thank you for having me.
Hi, my name is Kate Neville, and I'm a neuro-oncologist at Indiana University. And today I'm delighted to be talking to Linda Liau, professor and chair of the Department of Neurosurgery at UCLA, about her recent study and publication, Association of Autologous Tumor Lysate-Loaded Dendritic Cell Vaccination with Extension of Survival Among Patients with Newly Diagnosed and Recurrent Glioblastoma, a Phase 3 prospective, externally controlled cohort trial, published in JAMA Oncology in November of 2022. Dr. Liau, thank you so much for being here today and talking with me.
Thank you for having me.
So I remember when this paper was published because the neuro-oncology community was at a national meeting and, kind of wondering what this would mean. And we'll get to the details later. But since this paper has been published, I've had patients calling, emailing me, asking me about DCVax-L. And so for our listeners out there, what's the most important thing you think clinicians should tell patients when they call asking about this study?
This was a phase 3 non-randomized prospective cohort trial, an autologous vaccine for brain cancer that has shown some promising results. However, it is not yet FDA approved, so it is not currently available in the U.S. outside of clinical trials. And, and further clinical trials are ongoing using this agent.
I think in order to better understand the results of the study, which we'll get to, we first need to go over some of the methods and design and how you analyze the results. So do you mind giving us some background on that?
The study was initially designed as a phase 3 double-blinded randomized controlled trial with the crossover arm. However, as the trial was underway, we began to realize that because of the crossover arm, eventually about 90% of all patients received DCVax, either at new diagnosis or at presumed recurrence. There were actually several patients that, subsequently were probably found to have pseudoprogression. So in the end, it was depletion of the placebo control arm. Therefore, before the trial was ever unblinded, a prospective statistical analysis plan was designed to compare overall survival in the newly diagnosed cohort and the recurrent glioblastoma cohort of patients who are treated with DCVax with contemporaneous matched external control populations from control groups of other formal randomized clinical trials. Because I think because of the crossover arm, what we essentially had were two groups of patients, one who got DCVax early, at new diagnosis, and one who got DCVax at first recurrence. So those were kind of the two populations we were left with this trial, and that's why it was controlled to external controls. So yes, it's not a randomized controlled trial, but that is the background of the methods of the study. The comparator trials that were chosen based on predetermined criteria, and a broad literature search was conducted using these criteria, which included contemporaneous study time period, similar KPS and age groups, reported outcomes with overall survival, and various other criteria that are listed in the paper. So based on that, there were 5 newly diagnosed studies that were chosen for the comparator population, and 10 recurrent glioblastoma studies that were chosen for the comparator population for that group. And then our statisticians did do internal validation using various specificity and sensitivity analyses. So overall, that was the methodology of the study. And, I'm aware of the limitations of using external control populations. But given the conduct of the trial and the depletion of the placebo arm, we felt that this was a comparison that made sense and with its known limitations.
I think that brings up an interesting topic that maybe is beyond the scope of our discussion today, but about using these externally controlled cohort populations in cancer research specifically because of, some of the reasons that you mentioned, that the ethics behind not offering an intervention or ability to cross over for patients with cancer, especially patients with incurable cancers.
Yeah, correct. And at the time of the trial initiation, it was actually quite difficult to get patients to enroll because patients don't want to be on the placebo arm. And so the crossover arm was placed to allow for that option. But in retrospect, the comparators for this trial.
With that, could you please review the most important results of your study?
I think the most important results of the study are that the patients with newly diagnosed glioblastoma receiving DCVax had a median overall survival of 22.4 months from the time of surgery, 19 months from the time of randomization. And the patients with recurrent GBM had a median overall survival of 13.2 months. And these survival statistics compared favorably with that of the external control populations from over 1,300 newly diagnosed glioblastoma patients and 640 recurrent glioblastoma patients from various other published clinical trials. But what I think may be even more interesting is the long tail end of the survival curve and some of the subgroup analysis results that came out of the trial. For instance, the median survival of the MGMT methylated patients was over 30 months with an almost 20% 5-year survival. What was, interesting is that the majority of these patients surviving over 5 years are surviving without recurrence, which in the field of glioblastoma is actually quite unusual. So I think it does give us some information and data in terms of how to design future clinical trials and perhaps how to stratify patients for immunotherapy trials and potential biomarkers.
Yeah, I found that particularly interesting to the different subgroup analyses and the MGMT group specifically, which we know in general is a subgroup of patients with glioblastoma who in general we expect to live longer and have longer progression-free survival than patients who do not have MGMT promoter methylation present or have what we call an unmethylated MGMT status sometimes. But obviously more of a benefit you found in your study in that group of patients who received DCVax-L. But I was curious if you had hypothesized a mechanism or a physiologic, kind of pharmaceutical reason why the vaccine might work better for patients who had MGMT methylated tumors.
DCVax is an autologous dendritic cell-based vaccine that consists of a combination of a patient's own dendritic cells, which are antigen-presenting cells that are cultured from blood cells from the patient's blood. And then we put that in combination with a tumor lysate from the patient's tumor that is taken at the time of surgery. And the concept is that the dendritic cell or antigen-presenting cell is able to phagocytize and process tumor antigens from the tumor. And then the cell combination is injected back into patients to activate endogenous T cells. And we have shown from previous preclinical and early clinical trials that the use of dendritic cell vaccination with autologous tumor lysates does induce proliferation or infiltration of T cells into brain tumors, which we think is the initial first step for induction of an immune response in these brain cancer patients. One problem with immunotherapy for glioblastoma is that glioblastomas tend to be immunologically cold. There are no T cells in the tumor, so that's why a lot of these checkpoint inhibitors and other immunomodulators don't work as a single agent. So by activating the immune response using a vaccine, we're hoping that getting the T cells into the tumor will allow for kind of that initiation of immunotherapeutic response.
Yeah, really interesting. And I guess this would probably be a good time to, if you don't mind, just in really kind of basic terms, explaining what exactly the DCVax-L is and how it works.
The DCVax-L is a dendritic cell vaccine, and the L stands for lysate. So the dendritic cells are antigen-presenting cells. They're actually normal antigen-presenting cells in the body, but we've developed a way to actually grow them in large quantities outside of the body from taken from progenitor blood cells. And these antigen-presenting cells are then co-cultured with tumor lysate from patients' tumors. The concept behind is that because of the relative immune privilege of the brain, the dendritic cells circulating around do not typically encounter tumor antigens within the brain. So this is just a way to basically get the dendritic cells together with the tumor antigens. And then that itself is a vaccine that's injected back into patients to activate the endogenous T cells. And it's the activated T cells that traffic and migrate into the tumors to initiate an immune response. And that we have found in our previous preclinical and early clinical studies. That is something that DCVax can do. It does induce the trafficking of T cells into brain tumors.
So we were talking earlier, obviously, about the methods and design of the study and the externally controlled cohort. And we talked about that as one of the potential limitations of the study. In addition to that, any other limitations or challenges that you encountered conducting this study?
The patients treated with DCVax in the study were compared with the control arms of contemporaneous matched external controls who received standard of care alone. To mitigate some of the limitations using external controls, we did use a novel methodology to Neuro-Oncology called a MAKE analysis, which stands for Matching Adjusted Indirect Comparison Analysis, which matched patient characteristics between the trials as best we could at the population level. However, we were unable to obtain individual patient-level data from the previously published comparator trials. So we're not able to do individual patient matching, which we are all aware is a current limitation with the use of external controls. So I'm actually hoping that our publication and the discussions around it will spur the sponsors of these clinical trials to publicly release their individual patient data so that we as a field can further innovate and get regulatory interest in the use of external control arms in neurology and oncology trials. Because for patients with a deadly diagnosis, I think there's less and less interest in being the placebo control arm for large randomized controlled trials, especially since the data of standard of care is actually pretty well known from trials that we've done over the past 10 to 15 years.
On that note, for the individual patient data, how detailed would the data be?
I think even things that contain the typical prognostic indicators, age, extent of resection, MT methylation. It doesn't necessarily need to be terribly complex because, quite frankly, we actually don't have very many prognostic indicators in the glioblastoma field. But I think it'll open up a way to really get patient-level data. And I think the FDA is becoming more open to the use of external controls as the comparator arm for large clinical trials.
So how do you foresee these results potentially impacting patient care in the future?
I think for next steps for DCVax-L, based on what we've learned about the mechanisms of action and the potential biomarkers of response, we are currently conducting additional studies to look at the combinations of DC vaccines with various immune checkpoint inhibitors and immune modulators, so we can help to further enhance the efficacy, because even though there does seem to be a signal of efficacy with a almost 20% 5-year survival rate, that still means 75 to 80% of people aren't living 5 years. So I think we as a field need to do better. I think there's not going to be a one magic bullet that cures glioblastoma, but having different options available to patients for real-world studies of rationalized, personalized immunotherapy, I think would be useful for the field. So given the very favorable toxicity profile for DCVax and its potential efficacy, I do hope that it can be FDA approved someday and incorporated into testing various combinations, if not, standard of care in the future if these subsequent trials pan out.
So on that note, do you foresee DCVax-L being in a combination randomized controlled trial study looking at DCVax-L with a different agent, or another study with temozolomide in a randomized controlled trial setting?
One problem with a lot of randomized controlled trials is that it itself is also artificial compared to the real world use of a lot of our therapies. So whether I foresee another randomized controlled trial, I think it depends on the sponsor of the trial. But I think if we are able to get these options out to the community for testing, I'm hoping that there will be greater data that we can generate. Because I think one of the problems we have with a lot of these clinical trials of single agents is that without access to the agents, it's hard for people to do these combination studies. So I'm hoping that there will be innovation in the field in terms of how we can best move some treatments forward, given the current regulatory as well as, clinical trial environment that kind of limits, how we do larger trials with combination therapies.
So patients sometimes, especially since the publication of your paper, they call it and they ask, they understand that this is not an FDA-approved therapy, but how can they access DCVax-L right now? Is that information you can share with us? Could you talk to that a little bit?
DCVax-L is currently available for compassionate use in the UK. It was approved by the MHRA for that purpose. It's not yet FDA approved. And I think in terms of access to treatments, there's the balance between access and also getting more data and validation of efficacy. And I hope there will be a way future to be able to do both, to be able to allow patients access to treatments. And then I have the neuro-oncology community continue to test agents and come up with innovative trials to, prove or disprove efficacy. One problem is that unless you can get access to the agent, it's very difficult to do that. So perhaps a way to open access to DCVax for continued testing would be beneficial to the field.
Absolutely. And speaking just on a broader scope, patient access to medications is such a big issue in many fields of medicine, cancer care included, with insurance and approvals, let alone access to things that are not approved for compassionate use or, experimental trial use. It's a challenge, but I appreciate your comments and you being so candid about it.
A lot of patients now in the neuro-oncology community, they're just taking a lot of different off-label drugs that have even less proof of efficacy for glioblastoma, but it's FDA approved for another indication, and they want to try it, and neuro-oncologists are giving it. I guess my hope for DCVax is that maybe it could be accessible so that we can do these studies and allow patients the right to try.
Thank you so much, Linda, for joining me and answering my many questions in the dialogue about your study and DCVax-L and the challenges surrounding cancer clinical trial design. I really appreciated our conversation today.
Well, thank you. Thank you for having me.
Hi, this is Farah Mateen. I'm a neurologist at Massachusetts General Hospital and co-editor of the Without Borders section of Neurology. Today I'm pleased to interview Teddy Totimeh, consultant neurosurgeon, Accra Medical Center in Ghana, on the recent publication in World Neurosurgery titled Brain Tumor Programs in Asia and Africa, Current Status, Challenges, and Future Perspectives. Thank you for joining us today, Teddy.
Thank you very much.
In your paper, what components did you use to identify and characterize brain tumor programs?
We used 6 what we call pillars, or covariates, that would be things that we filtered from our own exposure in various brain tumor programs that we had been involved in, either as part of our training or as part of our practice. And then also what, the journal said about brain tumor programs. So we had 6 pillars that we used to be the anchors for any brain tumor program, which would be surgery, oncology, neuropathology, research activity, training and education, and then a financing program for it.
I'm curious, how many people are in your network in terms of the Asia-Africa Neurosurgery Collaborative Group? And then specifically in your paper, how many countries were invited and how many responded?
In the group, we have about 20 people. It's been a very fluid group. It's a WhatsApp group. It's based on WhatsApp. It's virtual meetings that have kept this going. And we had 92 countries that we reached out to. Now, it's important to note that the reaching out for these countries were done through Telegram or WhatsApp, and these were moderated by the various participants of the group. There were 92 countries, and we divided them to 3. So we had group 1, where we had response for neurosurgeons. So this were about 73 countries. And then group 2, where these were countries without neurosurgeons, but we got it from other neuro-related specialties. And then 16, where we didn't have a real response, right?
I'm curious, how many countries have no neurosurgeons?
So we had 16 countries with no neurosurgeons. And these are countries across from Asia and Africa. However, 90% of these countries were in Africa.
How did you categorize brain tumor programs and how did you score them?
We looked at the pillars and we sent out Google Forms based on these pillars, right? And the Google Forms were supposed to get the information back with responses related to these 6 pillars that we had identified. We realized that surgery, oncology, and neuropathology had the highest weighting in terms of influencing the standard of the brain tumor program, whereas research and training and finances did not, key in as much. So we put these together and we had marks that we gave according to the pillars. So the total score one would have would be 14 and the minimum score would be 0. So according to these scores, we're able to subclassify the brain tumor programs into 5. So level 5 would be the brain tumor programs with the highest scores, which would be 13 to 14. And then level 0 would be under 5. According to our scoring system, we had most brain tumor programs being in the level 3 range. So we had 29 countries being in the level 3 range, and then we had 5 countries being in the level 1. And then we had also 7 countries being in the level 5, right? Now, the thing was the standards were not equal in Asia and Africa, whereas you would have 42% of the countries that were assessed being in level 3 for Asia. It was just 25% of the countries that would be in level 3 for Africa. And the other thing was, level 1 was the countries that sort of scored under 5, and it was 0% in Asia and 9% in Africa. Whereas for level 5 countries, which basically are sort of top-notch and have everything, 14% of the centers from Asia were in level 5, and only 4% were in level 5 from Africa.
So if you had to summarize the main study findings, what would you say they are?
Across the low-middle income countries, the standard of brain tumor programs is generally low. However, Africa takes the big hit compared to India. Africa takes the highest number of hospitals with no neurosurgeons at all. And the other thing was the key pillars that would define what the quality of a brain tumor program is would be the surgery, oncology, and neuropathology. And which means that, creating a brain tumor program is very expertise oriented. It's very high skill related. And the key thing when it comes to going forward and improving the standard of these brain tumor programs is related to education and training. And these are not short-term things, because training these experts takes a long time. So we sort of had long-term interventions that we thought would be important, and then short-term. So for the short term, we thought that the concept of training would be with centers in, low middle income countries, getting together with centers in high income countries to sort of fast track the transfer of expertise. And then also really leveraging technology. Now with webinar training, Internet of Things, we can actually leverage on technology to fast track this expertise transfer. Training we can't get around. I mean, what I was doing in Minneapolis recently, it's basically going to a center which has a lab and dissecting and honing the craft. Now, this training has to be done in high income centers. However, this is where, looking at, funding and government involvement would sort of facilitate this part. The other thing was the long term should really focus on social advocacy, basically to influence government policies so that we can leverage the kind of exposure that neurosurgeons have and neuro-oncologists have to basically have country-to-country agreements that enable more people to be trained. And then also to leverage on the fact that, LMICs offer a very attractive setting for research. We have large treatment-naive populations with comparatively maybe high rates of CNS tumors if we were to take the data properly. Because at the moment, we are not really taking as much data from LMICs as we should, because 80% of the research takes place in the high-income countries. So basically, the fact that across board, we have similar issues with getting good brain tumor programs, but the fact that Africa is still quite way behind Asia when it comes to making strides to reverse this trend.
Many of our listeners are American-based neurologists, and I'm curious what you think we as neurologists and then the global community in general of neurologists, neuroscientists, neurosurgeons can do to support neurosurgeons like you and the growing collaborative in Asia and Africa.
I think it's really important to see that in multiple programs and, rich hospitals and rich systems in high-income countries, there's this increasing tendency for global care. And the truth is that the model that this has been based on has been, come on short term, do something, commando and go away. But I think going forward, we should think about more deliberate strategic engagements that allows centers to grow together and to catalyze this growth across continents has become easier. Traveling is easier. Webinars and trainings and things can be done virtually, So basically to start these conversations, right, that are learning conversations, which it's not just about throwing money at a project, but working with the people who are involved in the project so that there can be learning on both sides. Because truthfully, the world has become smaller and smaller, and COVID taught us something, that anybody can be locked down anywhere, and it's just essential to sort of democratize the access to good health care. The other thing is, in 50 years, it's known that Denmark, for example, will have a median age of 70. The median age in Africa will still be, in the 20s. At the moment, median age in Africa is 18, right? So the thing is, this place, Africa, is going to be the reservoir for human resource for the future. And the quicker these engagements take place to, provide some quality training for this reservoir, the better the community will be able to, take care of the world's need when it's time for Africa to step up and help. Because, nobody's going to train a 70-year-old medical student.
I wanted to ask you just about your own pathway to becoming a neurosurgeon. And for listeners who are not familiar, how many neurosurgeons are in Ghana, and is there a training program, and how do you become a neurosurgeon in a country without neurosurgeons?
Ghana started its local neurosurgical training in 2000. Before then, neurosurgeons were being trained outside the country. So our first neurosurgeon came to the country in 1967. He was trained in the UK, but basically we had a very barren time between the late 60s to the early 90s where there was no in-country training. Right. Since then, from about the late 90s, we got our first locally trained neurosurgeon. And since then, it's been additional. So we now have 26 neurosurgeons, but that is still grossly inadequate for a country of 33 million people. Right. So we have a training program that is accredited by the West African College of Surgeons. It's a 7-year program. You have to do 3 years of general surgery and then 4 years of neurosurgery, and then you graduate with a thesis at the end. Now, this general surgery plus neurosurgery thing is beginning to evolve, but the key principle for it was that every neurosurgeon would need to have some general surgery capacity, because generally you don't have enough surgeons across board anyway. So having highly specialized neurosurgeons was not going to be really helpful. But, we have now trained quite a number of general surgeons. And this year actually is when we have sort of graduated from the West Africa College of Surgeons being the only accrediting institution. And now we have the Ghana College of Surgeons. So we have a new faculty of neurosurgery in the Ghana College, which allows us now to have a straight 6-year program for neurosurgery without needing to do general surgery. And then you graduate with a thesis. Now, this program, it started this month. We've just taken the residents. So it's a historic batch of residents who are going to start this new program. My own route to become a neurosurgeon was atypical because I have done quite a bit outside the country. So it's been more of a winding road for me than most other neurosurgeons in the country. So I did my first 5 years in Ghana, and then I did 2 years in Israel. I came back to Ghana to write my West African boards, and then have continued working in Ghana since then. I did the traveling fellowship for pediatric neurosurgery in the US under AANS, and built on that, I decided to do a formal pediatric neurosurgery fellowship, which my boss in Miami Children's Hospital, who was my mentor during my traveling fellowship, was very kind enough to, recommend me. And I got a place in Liverpool, Alderhay Children's Hospital, where I did my pediatric neurosurgery fellowship. So back in the country, I do general neurosurgery and pediatric neurosurgery. I mean, the key thing is that with so few neurosurgeons, you can't do just pediatric. And so I do all across board. I think that my training in pediatric neurosurgery enables me to be a much better general neurosurgeon. And it also gives me the capacity to give advice to pediatricians and also to fellow neurosurgeons who may not have the scope of knowledge that I would have in it. That's basically my course in becoming a neurosurgeon.
And my last question for you is, do you have any comments on North-South and South-South collaborations? I know you've experienced both. Are they both useful, or some better than others at different stages of training?
I think North-South collaboration is essential because really that is where you get the expertise transfer, and that is where financing makes, sustainable, high-skill neurosurgery possible in our environment. It would be difficult to believe that in Ghana, the first aneurysms to be clipped in the microneurosurgical era were clipped this year, in January of this year. And this only happened because of a North-South collaboration with folks from Washington and then folks from the University of Ghana Medical Center. And I've hosted various groups from the US and then also from Europe, from the Swedish Neurosurgical Society, in doing surgical mission work in our environment. And those are useful. They're important, but it's even more useful to be strategic so that the engagement is not just related around the mission period, but it's also invested into training, and the training being, local-based training, because one of the biggest causes of brain drain is fellowship training in the high-income countries. Usually our neurosurgeons and neuro-oncologists, once they finish a fellowship in the high-income country, will have a job waiting. And the coming back becomes a difficulty because you have to accept low remuneration once you come back, right? So this local training, local North-South collaborations enable this expertise transfer to happen in the LMIC context, and it enables better retention of this expertise. Now, we should be having much more South-South collaboration because that's the situation. We just should be having more. What makes South-South collaboration difficult is, first of all, the low numbers of neurosurgeons. So basically, the high clinical load makes it difficult for you to even think about traveling to another country in the sub-region to do things. However, recently we have started discussions where for specialized surgeries like endonasal pituitary excisions, where the expertise is not that, well spread, some of us can go to countries which have neurosurgeons but do not have that expertise to do those surgeries on a mission basis, on a surgical clinic basis, and then come back. Those discussions have started, but it looks like for now it's going to be more North-South collaboration. But the other thing I've put to our collaborators from the high-income countries is also that we create some funding for colleagues from other countries to join us or to team up when the mission is starting, so that, if the mission is in Accra, we can create some funding so that colleagues from Cameroon, Nigeria, and Liberia can come at the same time. And this enables the partnerships that will push cell-cell collaboration and also basically catalyzes the expertise transfer.
All right. Thank you. This is Teddy Totimeh, and I really enjoyed speaking to you. So thank you so much for your time today.
My sincere pleasure. Thank you for having me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.